Hello, Dr. Gordon. I would like to ask you if maybe you could tell how did you get involved in medical education?
Well, it goes back to when I was a medical student, and it was in the days when you spent 3 years in a separate university and then 3 years in a more clinical school, and the quality of the teaching in the clinical school was so bad that I thought something must be possible to be done about it. So after I qualified, about 2 years after I qualified, I was offered a research position in a medical school, but as well as doing research, I got actively involved in the teaching to try and make it better. And I've been involved in one way or another ever since. I was at that medical school for some 15 years, but after that I worked in a research funding organisation, but I maintained my interest in education right the way through.
Okay, and WHO defines future doctor as a 5-star quality specialist. In your opinion, what's the best way for a medical student to acquire these qualities?
It's very difficult to look into the future because medicine changes unimaginably by year and year, from one decade to the next. It becomes almost unrecognizable. So the most important features, I think, are for the student to study in a high-quality course where he or she not only learns about medicine as it is today, and learns about the things around medicine, the ethics, the handling of the individual patient, the issues of health economics and law and so on, but learns about medicine as thoroughly as possible, but also learns how to learn, so that he or she in the next 5, 10, 20, 40 years continues to actually absorb new knowledge. There's some evidence that doctors are at their most efficient in general when they have completed their specialist training, about some 5 to 10 years after they qualify, and their performance gets a little bit less efficient after that time. So it's very important for us to make sure that we not only learn everything up to the time that we become a specialist, but also that we learn how to keep up with our specialty as it evolves. I think the other thing that will help make sure that the student becomes a 5-star doctor and remains one is that not only is there the intellectual effort to keep up with medical science and medical practice, but there is also the right set of personal qualities which are not only to deal with the individual patient, but are also to deal with society in what it requires of doctors, to help to take a role in the healthcare team, often leading, but not always being the leading person in the team. So all those personal qualities are, to my mind, almost as important as the intellectual ability.
And usually medical students face the culture of we're going through that, you will go as well, do not complain. Do you have any advice how to change such attitude?
Well, I would start off by treating such attitudes with scorn. Anyone who says things were bad for me, so they're going to be bad for you, what kind of person is that? That's not a very practical thing to say to your professors, I treat you with scorn. So I think there is a need to actually develop throughout the profession an ethos that if things were not good in the past, we will make them better. And that doesn't just mean not good for our patients, it means not good for our fellow doctors, for the other professionals who work with us, and for medical students. I think I see in many countries signs of the attitudes improving. Certainly in my own country, in the United Kingdom, medical graduates now are treated with more respect than they were when I qualified, and medical students during their course, I believe, get more respect. And the idea that something was bad and difficult, therefore everyone else has got to suffer it, is gradually going. But I appreciate that in some other cultures and in some countries that's going to take a long while to go.
And is there a way how can the medical academic community change the relationship between a student and a doctor from vertical to horizontal?
Well, When I used to speak at the introduction of new medical students in the medical school that I led, I made the point, and I also made it at the graduation ceremony as well, that a university, a medical school, is not a set of buildings and laboratories and equipment and books and so on, and it's not just people who teach and do research, but it is altogether a community of the academic staff, the students, and those who work with them. That community in medicine therefore includes the healthcare community, the staff of the hospitals and clinics where students study and learn. So if we foster that attitude that a university is a community of people, it is not a hierarchy, then that will make the structure more horizontal in the way that you describe. Again, I think this is difficult because in many places attitudes are very deeply entrenched, and I can't promise an easy way to shift them. All I would say is that the evidence is that in academic communities where students are treated with respect and treated as equals, but in a different stage of their career to the academic staff, then academic performance improves. Another way in which this attitude changes is through the action of larger organisations, not just the individual student or within the individual university. And organisations such as the World Federation for Medical Education and the International Federation of Medical Students Associations are very important in actually leading attitudes and practices. So we have written into the standards for medical education a lot of material about the relationship of the students to the medical school and of staff to the medical school and to each other.
And how should comprehensive modern medical curriculum look to meet the needs of future society?
Curriculum development and curriculum planning is an extremely complex subject. Over the last 50 years, there have probably been 5, 6, 7 different models of the curriculum that have been favoured at any one time, but with very little evidence that any one is better than any other. We've gone from the student-led curriculum. If you go backwards, you have ones concerned with teaching style and teaching methods, and forward to things arguing about the social responsibility in the curriculum and so on. A curriculum is actually a complicated social, psychological and educational construct, and the most important thing is for it to be appropriate for the context in which it is being used. A curriculum that is completely appropriate and timely for one medical school will not necessarily be right for another medical school, even at the same time. Students need to learn different things if they are working in rural Sudan than if they are working in California. They need the same basic knowledge, but the finer points of the curriculum will be very variable. So a comprehensive modern curriculum is one that is appropriate for the context. I think we should never attempt to make one that is appropriate everywhere, but we can make standards that are appropriate everywhere. So don't define too closely what has to be learned, but define very carefully how well it should be learned and how well it should be studied.
And what do you think about a potential solution for the lack of physicians by increasing the responsibilities of other health workers?
Well, in any well-organised healthcare system, it is obviously also already teamwork. It's not just doctors, nurses, physiotherapists, social workers and others. And the extent to which medical interventions and medical practices can be replaced by interventions from other professions all the time needs to be thought through. There are undoubtedly some areas of medicine where team working has already shown its efficacy. For example, in acute psychiatry, where a psychiatrist working alone is a lot less efficient than a psychiatrist working with a psychiatric social worker, with psychiatric nurses, with psychologists if necessary, and with the social services to actually make sure that the best outcome for the patient follows. And there are also some other areas where another professional will very suitably take over from the physician. For example, a lot of the day-to-day care of a new diabetic may best be handled by a nurse specialist rather than all the time needing a doctor. And sometimes, if the new diabetic is a child, a nurse specialist may be easier and less threatening, and so the outcome may be better. So there is undoubtedly more opportunity for team working and some opportunity for shifting work from physicians into other members of the healthcare team. We at the World Federation are engaged in a project to look at what the future role of the doctor will be, and it's clear that one conclusion is that the doctor, he or she, will always be a member of the healthcare team, will often lead it, but in some circumstances will not necessarily actually be the lead of the healthcare team. It might be better for someone else to have the skills to do that. I think this needs to be viewed in the light of existing circumstances. For example, there are some countries where there are many more physicians than there are nurses, and so work that we might expect to be done by nurses is actually done by doctors. And there are other countries where the esteem of the nursing profession has been built up so that there is less work being done by doctors than we would normally expect. So this needs to be looked at in the light of history, but I think the balance will improve and it should make it possible to match the work more exactly to the particular skills of each profession.
And could the problem of too few health workers be solved or achieved by automation, robotics, or even artificial intelligence?
Well, we're already there. And indeed, we have been there since the day when Laennec lifted a wooden stethoscope to his ear and listened to the chest of a patient. You know, that's a little bit of automation. And the machinery, in the widest sense, that will help us is developing all the time. It was unimaginable when I was a student that you could have a thing such as a magnetic resonance image that would actually help you see all sorts of processes that we actually had to look at by much more devious means. So that's a way in which automation has actually already advanced what we do. I think the extent to which it will do the work that we do is difficult to predict. I suspect that high-powered artificial intelligence will do quite a lot in terms of extracting information from what the patient says or what the doctor says to the patient. I think there will be many tasks that will be taken over by robots, whether particularly medical tasks. Robotic surgery is already far advanced, but also some of the more simple tasks involved in healthcare, such as helping the patient with a meal or with the activities of daily life. I think there are a number of areas we have to think about with care. I don't think the robot or the computer and its AI will ever substitute for the necessary human interaction. And I think although many of us find our machines quite comfortable to be with, some people seem more interested in talking to their phone than talking to their friends. But I think in the matter of healthcare, we will always need the real interaction with a real person. And the algorithms that the human brain works through in actually coming to a diagnosis or working through treatment are sometimes much more complex than we realize at the moment. So it's going to take a long time. We don't know where it will go. We don't know what the end will be. But I think there are very large, very considerable possibilities. But we have to keep an eye on it.
And then what do you think, who should be responsible for the planning the amount of future doctors and medical students nationally and internationally?
That's a very big question. It's a big question, first of all, because we have very little data on how many doctors there actually are, or very little data on how many medical students each country takes in each year in relation to the number of doctors in that country. One of the earliest bits of work in this area was actually done in Lithuania by Professor Grabauskas, who looked at a number of countries in Europe, and at that time, about 15 years ago, there were roughly 100 new medical students for each million of the population in a wide range of European countries. Now, that has already changed for a number of reasons. People are maybe working slightly shorter working lives, maybe they're getting longer. Female doctors obviously will have more pressure to take time out from their career than male doctors, but I hope that will evolve and men will take more responsibility for looking after their children. The numbers change also because medical care becomes more complex and the demands for people to work in the system increase. But at the same time, as we were talking a little while ago, automation, artificial intelligence may take some things over. So we have very little data on the number that there are and the number that in present circumstances that we need. We certainly know that there are distorting factors which are either to be argued against or indeed sometimes to be deplored. The distorting factors include economic factors where in a particular country doctors tend to emigrate to earn a better living, to have a safer life, or where they tend to immigrate because they can see possibilities for a better career. There are political factors where politicians can gain prestige by saying, I have arranged for a new medical school in my city, without thinking through whether the new medical school is really needed. And by international coordination, we need to understand that medical schools can sometimes grow in number, either for those political reasons or for financial reasons, medical schools being started to make a profit. The World Federation for Medical Education actually has a guidelines paper on criteria to be considered when you want to start another medical school. And they are very basic things that have to be thought about, but we can see in many cases they are not considered. Is there a real need for the number of doctors that are proposed, or could that be met by other healthcare professions? Will there be suitable students in suitable numbers and a good enough quality? Can staff be recruited? Is there a financial plan? And so on and so on. Even down to very basic things like, are you planning a medical school in a place where it can be connected to the water supply or to the drains? But these are very simple things that in many circumstances are not thought through. Now that paper we have on the website, but it's a paper in development because we want contributions from people who've met difficulties in starting a new medical school and actually will actually think that through. The number of medical schools, of course, is not very tightly related to the number of medical students, but it's one of the factors. Internationally, who should be responsible? I think the WHO, with organisations like IFMSA, the World Federation for Medical Education, the World Medical Association, should work to develop at least a policy for thinking through what those numbers should be. It would be a very worthwhile piece of work to do thoroughly, but whether it would have as much influence as it should have depends on whether the political and financial and other factors are kept under control.
Thank you very much. It was Dr. David Gordon.